All right, good morning, everyone. Let's get started. It's my pleasure to welcome you all to today's Region 4 Project Echo session from the Emory University Serious Communicable Diseases Program, run in conjunction with the Southern Regional Disaster Response System and the National Emerging Special Pathogens Training and Education Center. My name is Gavin Harris. I'm an adult infectious diseases and critical care physician, the Director of Regional Education and Training for Emory's Serious Communicable Diseases Program, and your host for today. As always, before we begin, please know that we will be recording this session, and your data, while used for informative purposes, will be kept confidential. For those who don't know, ECHO is an acronym standing for Extension for Community Healthcare Outcomes, founded by the University of New Mexico. It's designed to amplify and disseminate best practices in a collaborative and interactive manner. And if you're interested in participating in future sessions, please reach out to us. Details will be at the end and on our website. As always, if there are any issues during the webinar, please send us an email or type in the chat. If you'd like to ask a question during the session, please type it into the Q&A feature. We'll do our best to answer all questions in real time, and we'll discuss as many questions live as we are able. If we don't get to all those questions, we will be posting a recap addressing the topics on our website when the recording to this session is made available next week. The presenters and the planners of this session have no financial conflicts of interest with ineligible companies to disclose. And here's today's agenda. We will start with the Region 4 SITREP as always, followed by our case and didactic presentations with moderated question and answer session to follow. With 3 months to go until the FIFA World Cup here in the Western Hemisphere, each of these monthly sessions explore a different aspect of relevant disaster preparedness, and this month we continue with high consequence infectious diseases preparedness. And now it's my honor to introduce our guests for today. First, joining us from Argentina, I would like to welcome Dr. Anabel Sinchi, a public health physician who specializes in viral hemorrhagic fevers and other emerging and vector-borne diseases. Dr. Sinchi currently serves as head of department for the National Institute of Human Viral Diseases, Dr. Julio E. Maiztegui, in Argentina, where she directs initiatives related to surveillance, research, and control for these pathogens. She has been a leader in development of national guidelines, training, and capacity building, as well as the coordination and implementation of response. Dr. Sinchi has also been called upon as a technical advisor to both the Pan American Health Organization and the World Health Organization, or WHO. Next, I'd like to welcome Dr. Gaby Frank, Professor of Medicine PAR and Hospitalist at Johns Hopkins University and Hospital, where she also serves as the Director for the Johns Hopkins Special Pathogens Center. Dr. Frank is also a national leader here in the United States, directing initiatives for NETEC and the Special Pathogens Research Network, or SPRN. Her interests span emerging special pathogens, disaster preparedness and response, and medical education. And lastly, I'd like to welcome back Dr. Jessica Pavlik, Acute Diseases Epidemiology Director and Epidemiology Preparedness Director for the Georgia Department of Public Health. Dr. Pavlik has almost 2 decades of public health service and experience in epidemiology and emergency preparedness at both the local and state levels. She currently oversees a wide variety of surveillance, planning, and preparedness activities for both natural and deliberate biothreats, and I dare say is SCDP's close colleague and go-to collaborator for many preparedness initiatives here in Region 4. Welcome to you all. And as always, to place this session in context, the Emory University Serious Communicable Diseases Program, in conjunction with the SRDRS, puts together situation reports on special pathogens of concern for our region, HHS Region 4. These SITREPs are typically published on our website, social media channels, Emory Department of Medicine YouTube channel, and listservs. And here is the current HHS Region 4 Special Pathogens SITREP. First, to Nigeria, where Lassa fever continues. In the most recent situation report from the Nigeria Center for Disease Control and Prevention, covering the 30th of March to the 5th of April, 170 deaths from January through the first week of April have been recorded, a continued increase. The case fatality remains steadily above 20% at 24.8%. By comparison, the CFR was 18.8% by the same time last year. Out of the 36 states in Nigeria, 22 have recorded at least one confirmed case this year, and again, the predominant age group affected remains the 21 to 30-year-old group. This is the peak season now for Lassa fever, and the regional risk of spread remains high and global risk remains moderate. Next, to South Sudan, where last week an as yet undiagnosed event was reported. There have been 3 suspect cases of viral hemorrhagic fever reported in Lotomor in the eastern Equatoria state, with the 3 patients reported to initially have vomiting, diarrhea, high fevers, and bleeding. A high-level investigative team with support from the WHO has been deployed to investigate, and as of now, testing remains in progress. I next wanted to take a brief moment to address diseases that we are following in anticipation of the World Cup. Each of our echo sessions, as I've mentioned for the past 6 months, has dealt with topics or disease processes related to the World Cup, and with the group stage matches being set for Atlanta and Miami, as you can see here, we have been working with partners to identify specific risks that players and their support personnel and fans may pose in coming to Region 4. Of course, we recognize that diseases may not necessarily come from elsewhere, but there are certain high impact and high consequence diseases of which first responders and receivers should be aware, and for which our healthcare system can be pre-positioned. If we then interlay this with a list of selected HCIDs, as you can see here, there is a method to our curriculum. Again, this list is not all-encompassing. As you can see, for several of the countries for which we are going to be discussing South American hemorrhagic fevers today, this certainly has relevance. Crimean Congo hemorrhagic fever, filoviruses, MERS, which we've already discussed, and other diseases that you can see there too. Finally, there have been no reports of suspect or confirmed patients with special pathogens of concern in Region 4 at this time. For more resources, visit us on the web at scdp.emory.edu. And now, as always, before we delve into the main topic at hand, I'm going to pose first some interactive poll questions to our audience to gauge base comfort level with this topic. They should be up on the screen now, and if the audience could please vote now. The first question, how knowledgeable do you feel about the clinical management of a person with a suspect or confirmed case of South American viral hemorrhagic fever? And the second question, how confident do you feel about utilizing the processes of identifying, isolating, and informing as it pertains to encountering a person, again, with a suspect or confirmed case of a South American viral hemorrhagic fever? I'll give you a short bit of time to answer those questions. All right, and if we could please place the results up on the screen. And for the first question, we seem to have quite a wide range, which is absolutely fantastic. We have some folks that are not at all knowledgeable as well, so hopefully this will be an educational and important session for you all. And again, there's a wide range for the second question about implementing, identify, isolate, and inform. So with that, our panelists certainly have their work cut out for them, but I'm going to turn it over to Dr. Sinchi to begin.
Hi, Gaby.
Hello there.
So you are listening to me?
I can certainly hear you. If you're trying to share your, yes, if you are sharing your slides, we cannot see them as of yet.
Okay. Okay, I think we are okay with this.
Absolutely. The floor is yours.
Okay, thank you, Gavin, and thank you, all of you, for the invitation, all the present, for the time you are taking to hear about this case of Argentina hemorrhagic fever. So, I'm going to start with saying that we have this patient, a 39-year-old female. She is a resident of Rosario City in Santa Fe province of Argentina. She lives and works in an urban area. She had regular outdoor activities outside the city on weekends. She has no known comorbidities, and she is not vaccinated against dengue, Argentina hemorrhagic fever, or yellow fever, but she had complete MMR vaccination schedule. She has travel history. She traveled to San Carlos de Bariloche and Rio Negro from February 14 to 18. So she did recreational hiking there, and she stayed in tents in a mountain forest area. She had no similar illness among household contact or travel companions. So, on February 24, she started with asthenia, myalgia, headache, and retroorbital pain. At February 26, she has her first outpatient visit, and she refers fever for 24 hours, persistent asthenia, myalgia, and headache, and she was prescribed acetaminophen, and they said to return with precautions and for close follow-up. She came for the outpatient visit on March 12, day 7 since the start of the symptoms of the disease. She refers fever, headache, and myalgia that persist, low back pain and arthralgia, nausea and diarrhea. She refers occasional dry cough with no upper respiratory illness symptoms. She refers menstrual bleeding earlier than expected, and she seems irritable, mildly slowed, but she's fully oriented. At the physical examination, she presents erythematous rash involving the face, the neck, and the upper trunk, conjunctival injection, bilateral periorbital edema, and oropharyngeal enanthem characterized by increase of vascular pattern of the soft palate and petechiae and microvesicles. So she also have petechiae in the inner aspect on both arms and small and non-tender cervical lymphadenopathy. Respiratory examination was unremarkable, and the other physical examination was unremarkable. So they performed a chest X-ray, which also unremarkable, and did a laboratory, and this is where the finding. They had an hematocrit 41%, the white blood cells counts, they have leukopenia. This is the formula they can see. And the platelet count also is down, they have also a plaquetopenia, and the erythedimentation rate is normal or down. Liver function test with normal limits, and they perform an urinalysis. The only remarkable thing that they found this was trace of protein, and the microscopic sediments was also unremarkable. So, sorry. She was admitted at the hospital on day 7. So we are in March 2, day 7. The initial differential diagnosis that the clinical thing was dengue, Argentina hemorrhagic fever, chikungunya, hantavirus infection, and leptospirosis. So we are at the day 7. They perform a rapid test of dengue, which results were negative. And the initial etiologic study, they asked for Junin real-time PCR, but it's pending at the 7th day. They performed dengue, so dengue PCR and IgM was negative. Also chikungunya, hantavirus, and leptospira PCR also were negative. As we are in the 7th day of evolution of the disease, the physician decided to treat the patient as an Argentina hemorrhagic fever suspected case with immune plasma in standardized doses. And this was because the early studies were unrevealing. However, the epidemiology, the bedside syndrome, and the evolution remain highly compatible with Argentina hemorrhagic fever. And finally, they got the blood and urine cultures. It were also negative. So we still on March 2, the immune plasma was transfused to the patient, and at the other day, and day 8 of evolution, March 3, she she have unmarked early improvement. She was febrile, good general condition. And March 7, the day 12 of evolution, she already have a laboratory normalization, clinically, laboratory parameters return all to normal, so she was discharged from hospital. The same days, they got the result for Junin real time, were positive or detectable, and the final diagnosis was Argentina hemorrhagic fever. She was cited for outpatient follow-up on March 18, and she was afferile. The exam was unremarkable, good general state, and she refers mild asthenia that persists. After 4 weeks of, she was readmitted at hospital for presenting 3 days of fever and headache, diplopia, nausea, moderate ataxia over the previous 24 hours, and that at the neurological exam, she had bilateral 6 cranial nerve palsy. They did a cerebrospinal fluid test. They was clear with moderate pleocytosis, normal glucose, mildly elevated protein, and the direct virus bacteriologic examination with not organic scenes, and the culture remained negative. They performed FILARI for meningitis and encephalitis panel, was so negative. It is for common, maybe you are familiar with FILARI. There's a test that you do. We were searching for example, meningococcus, some bacteria, cryptococcus, and also another virus common in this kind of clinical presentations. And also this was performed after, but Junin virus real-time PCR was negative. They did a brain CT with no intracranial hemorrhage, no mass effect, no evident focal lesion, and the overall interpretation within normal limits. So the clinical impression for clinicians was Argentina hemorrhagic fever, late neurological syndrome. The management of this syndrome is only symptomatic. They don't have a specific treatment. She already had the specific treatment for Argentina hemorrhagic fever, which was plasma immune, or immune plasma, sorry. She progressively have only progressive improvement and was discharged after 10 days, asymptomatic and afebrile. So, on May 2 months after the start of the symptom of Argentina hemorrhagic fever, the patient have final outpatient follow-up with good general condition and was taken a second serum sample for serology. And we have the results of serology for Junin virus that we have a seroconversion there. So we already had confirmed the diagnosis in the acute period, but we also do all the time the serology same. So the final diagnosis was Argentina hemorrhagic fever complicated by neurologic syndrome, late neurologic syndrome. Finally, some review. The usual clinical course of Argentina hemorrhagic fever is an acute febrile illness without upper respiratory tract involvement, and the early phase, as you see, there are no specific symptoms with limited hemorrhagic and neurologic manifestations. They have progressive leukopenia and thrombocytopenia without a specific treatment. Approximately 30% of the patient progress to severe disease. And this severe disease may include major hemorrhagic and or neurologic manifestations, shock, and secondary bacterial infections. The mortality in this severe form reaches up to 90%. So after that, convalescence is prolonged and full recovery may take 1 or 2 months. The more characteristic thing that you are seeing is asthenia or hair loss, but everything is transitional. Approximately 10% of patients treated with immune plasma may later develop this late neurological syndrome after a symptom-free period of 3 to 4 weeks. Argentina hemorrhagic fever is a zoonosis. In Argentina, it has a reservoir, Calomis musculinus, who develop chronic infections and eliminate virus through saliva, urine, and fecal matter. So the transmission to human is through aerosolization of this excreta. And if very infrequent, but we have some human-to-human transmission. So the first outbreaks of this disease in Argentina were detected in the 50 decade. So the isolation was in 1958. They named Junín because Junín is a city here in Argentina in the endemic area. So in 1978, a National Institute of Human Viral Disease, Dr. Julio Maiztegui, the institution I belong, was created for our Ministry of Health in Argentina with the aim of create the national program for the control of Argentina hemorrhagic fever. Since then, since 1928, we developed a strong epidemiological surveillance. We developed a clinical diagnosis algorithm, etiological diagnosis, a specific treatment, as you see, plasma immune. We create an immune plasma bank network in order to treat this patient and also do health education, human resources training, research. And finally, in the 90s, we have the opportunity to do vaccine clinical trial with Candid 1 vaccine. And in the 90s, we have this live attenuated vaccine that have efficacy of 95%. Is very secure and very optimal vaccine. So in the 2006, the vaccine, the original vaccine we developed between Argentina and the United States, and the vaccine was produced originally in the US, but they transferred the technology here in Argentina. So now we produce our own vaccine here in Pergamino and in a National Institute and my institution. We produce the vaccine for all our country, and since 2007 we have the vaccine incorporated in the national immunization calendar. It's a vaccine that is free for all people who live and travel for our endemic area. You can see here in the map, this is a map of Argentina. And you see in red is our detected endemic area. So that we are detecting cases since the 50 decade. And this is the final algorithm for suspicion. A patient with not a specific febrile syndrome with the endemic area or visit in the previous 3 weeks, because the incubation period is up to the longest incubation period is 3 weeks. So this case with blood cells that he had less than 4,000 white blood cells and less than 100 platelets counting, this is a definition for suspected case here in Argentina. And in that case, a physician has complete the mandatory notification form because it's a disease under mandatory surveillance. We collect and send samples for diagnosis. We also do the diagnosis here in Argentina at the National Institute of Human Viral Diseases, and also ask for our network, ask for the treatment for the plasma for the treat the patient. Since the start, our program gets one annual meeting when all the people that work in all these activities I mentioned we get together and our annual meeting. This is pictures of the last meeting last year in September, was in Rosario City. But these meetings are taking place in other cities every year in order to the local health system have the opportunity to come. And you also are invited if you are in Argentina next October, that we are also thinking to do the 40 meeting. So thank you very much.
Dr. Sinchi, thank you so much. That was a fantastic presentation and a clinical case. In the interest of time, I think we're going to hold questions for a little bit later. So next, I'm going to turn it over to Dr. Frank. So Dr. Frank, we can see your slides, but we cannot hear or see you if you are talking.
Well, because I talk too much, so I put myself on mute and I forgot to unmute myself, but I was talking.
Well, we can hear you.
I was introduced already, so let's move forward to the slides so we can get to some of the important issues. So all the images are credited with permission, are used with permission and credited or licensed via Shutterstock. I have no conflicts of interest. And Dr. Sinchi just introduced us to Argentine hemorrhagic fever, which that was a fantastic case. And I hope you all got like, oh my God, I need to pay more attention. How do I get to diagnose these patients if I ever encounter them? So as a quick introduction, South American hemorrhagic fevers are a group of zoonotic viral infections that are present in South America. They do have the potential to cause severe illness, leading to organ dysfunction, bleeding, and death. They are caused by arenaviruses. And you can see, like, if you think about arenaviruses, think about Lassa. And that was one of the pathologies that were discussed initially in the current status of diseases, particularly when Dr. Harris was discussing the cases in Nigeria. So arenaviruses are enveloped, ambiguous, segmented, single-stranded RNA viruses. And this is something that we're going to go kind of fast because we want to talk about how to diagnose these cases, when to think about these cases. So we're going to move somewhat fast on this, but arenaviruses, we have the old world arenaviruses, and the big example is Lassa. And then we have the new world arenaviruses, and those are the ones that we find in South America. And we're not going to talk about the whitewater arroyo, but I can refer you to some publications if you want to read about the 4 cases in 1990. So for the new world arenaviruses, the ones that we find in the Americas, there's 4 different clades, and all of those that cause hemorrhagic fevers are part of the clade B. Nothing that you need to know, but it's kind of cool to say that out loud. So we will have, there's a lot of different viruses that can cause disease in humans that are part of this clade B viruses. The one that is the most important, that have been known the longest and have caused the highest numbers in cases is Hunin virus. That is the causative agent for Argentine hemorrhagic fever. That is the case that Dr. Sinchi described. We can see that the reservoirs, the most common reservoir is Calomis musculinus, but there's other reservoirs that can carry the virus as well. And as you already know, it can cause disease in humans. The next one is Chapare virus and Machupo virus. They're both found in Bolivia. You can see that for Chapare, we don't know what the reservoir is. It's also thought to be a rodent. However, it's still unknown. And some of you may have, it's like, oh, I read about Chapare virus in the New England Journal of Medicine in 2019. Yes, there was a cluster of 9 patients in 2019 that actually made it all the way to the New England. And that is because out of the 9 cases, 5 patients were deceased. And a lot of them, like 3 were healthcare workers, right, that were exposed to the initial case and ended up sick. So this is why it's important to think about diagnosing these cases so we can take the appropriate precautions. So this is where we go to the identified, isolate, and then inform. So we need to identify those cases first, and all comes to asking the right questions and think about, well, I'm not an expert in this, but I don't know enough. So how about I isolate this patient and then ask more questions? Machupo virus is the causative agent for Bolivian hemorrhagic fever. And we have the reservoir that is Calomis calosus, and we can see that was identified in 1963 and is known to cause disease in humans. Takaribe was found in Venezuela. This is the reservoir is on yellow because this is the only one that we know of that the reservoir is a bat instead of a rodent, and has caused a non-fatal laboratory-acquired infection, but is not known to cause disease in humans in the wild. Then we have one virus that causes Venezuelan hemorrhagic fever, and we can see the reservoir is Zygodontomys brevicauda, also causing disease in humans. Savia virus, that is the causative agent for Brazilian hemorrhagic fever. We do not know which the reservoir is. There have been a total of like 9 to 10 cases so far described, and is one with the highest mortalities. And then we have Amapari and Kupixi that are not known to cause disease in humans. And we can see some of the pictures here of Calomes musculinus, Calomes callosum, and the Zygodontomys in the bottom, like brevicauda. So all the biggest reservoir for either Argentine hemorrhagic fever, Machupo, that is Bolivian hemorrhagic fever, or Venezuelan hemorrhagic fever. In the map, you can see the endemic areas for each of them. So how do we acquire is South American hemorrhagic fever? As Dr. Sinchi said, this is a zoonosis. So basically, we need to have contact with infected rodents and their environment. So usually what happens is that this virus causes an asymptomatic chronic infection in rodents, and the virus will be live in all the excreta of the rodent. So when we aerosolize these particles, when people are working in agriculture, is when we actually get exposed, either by exposing through the skin because of cuts, or injuries, or by inhalation of the aerosolized viruses. Person-to-person transmission has been described for a lot of arenaviruses. The ones that are particular to today's talk is Junin, Chaparema, Chupo. Lassa and Lujo are from the old world arenaviruses. And those were both from household and nosocomial. And I just told you the case about the Chapare cases in 2019. And again, if you do Chapare New England Journal, you will see that article just to get a better idea of all the cases. They have in descriptions of laboratory-acquired infections, particularly for Savia virus and Takaribe, and sexual transmission. This is mostly for Junin virus as well as Lassa. So again, we can see in the table below is from one of the articles that is a review article for South American hemorrhagic fevers. And again, it's most the same of what we have discussed. So the clinical phases, all of these diseases share some commonalities, particularly clinically. So the incubation will be 3 to 21 days. We're going to have a prodromal phase that is usually the first week of symptoms, followed by the acute disease or acute illness phase that is usually in the second week, followed then by convalescence. Another way to see it is like here, the incubation 3 to 21 days, the prodromal phase that is going to be a flu-like syndrome, some fever, malaise, the illness that is usually days 7 to 12, when the patients are going to develop either gastrointestinal, neurologic, or hemorrhagic symptoms, followed for those who survive the convalescent phase that can last up to 3 months. And for Argentine hemorrhagic fever, there is the case of late neurologic syndrome that was explained by Dr. Sinchi, but we will see a little further in like 2 more slides. There is a spectrum of disease, correct? Not all the patients will develop the hemorrhagic phase, but 30% of those patients will, particularly if not treated for Argentine hemorrhagic fever. Early administration of convalescent plasma is key. And this is some of the characteristics of the big ones. So Argentine hemorrhagic fever, Bolivian hemorrhagic fever, Venezuelan and Brazilian. So some things that are very characteristic for each of those. So the late neurologic syndrome is characteristic of Argentine hemorrhagic fever. And we can see how the mortality for the disease is 15 to 30%, but that decreases to less than 1% if we administer early convalescent plasma. Another thing that is somewhat characteristic is that virus, or that is the causative agent of Venezuelan hemorrhagic fever, may present with upper respiratory symptoms. That is not characteristic in all the other ones, South American hemorrhagic fevers. However, is very common in Lassa fever, which is the other arenavirus from the old world arenaviruses. So late neurologic syndrome. And again, this was described by Dr. Sinchi, so we'll try to go somewhat quick through this so we can get to like all the presenter that comes after me and then questions afterwards. But usually this presents in 10% of the patients that receive Hunin convalescent plasma. So you would think, why would I give someone convalescent plasma if that increases the risk of developing late neurologic syndrome? And the rationale is because if we administer convalescent plasma, we decrease the mortality from like up to 30% to less than 1%. So it's very important to actually do early convalescent plasma. Also, this 10% of patients developing late neurologic syndrome is most common in those patients who receive the convalescent plasma more than 8 days from the onset of illness. This is why thinking about the disease and trying to make an early presumptive diagnosis or suspected diagnosis is important to try to acquire the convalescent plasma and give it to the patient. So the most common presentations are usually dizziness, headache, and nausea after recovery. So the patients will have a period that is symptom-free. They recover, as you saw in the patient from Dr. Sinchi. Patient presented March 3rd, was discharged like 2 weeks, and then returns in April 2nd after being free of symptoms for a couple of days with this late neurologic syndrome. Usually they will redevelop fever, and they will have cranial nerve palsies, and the 6 nerve palsy is common and is present in up to 60% of the patients with late neurologic syndrome, followed by cerebral deficit, with nystagmus being present in up to 50% of these patients. In almost 2/3 of the patients with late neurologic syndrome will develop either tinnitus, blurred vision, gait ataxia. A lot of them will have diplopia, and some of them will have either hyperreflexia, extrapyramidal signs and symptoms, and other types of paresis. And Dr. Sinchi already described the CSF particularities of neurologic syndrome. Is usually lymphocyte predominant. They will have, in most of the cases, normal glucose and protein. And what is interesting is the antibody titers to Hunin virus are higher in the CSF than it is in serum. This is suggests an immune-mediated mechanism. However, this is still up to discussion what the true mechanism for late neurologic syndrome is. And what is important to note is that all the symptoms are transient. So usually can last from a few days to several months, but most of the patients would recover completely. So what are the mortality risk factors? So which one of my patients with the South American hemorrhagic fever will have higher mortality risk? And this is kind of intuitive. Yeah, those who develop hemorrhagic features, those who develop neurologic symptoms, those with shock or multi-organ failure, and those who actually develop bacterial superinfection. Those patients as well with marked thrombocytopenia and leukopenia. When we talk about elevated TNF, interleukin 6, 8, 10, we don't check that routinely in most of our patients. So that shouldn't be, it's not that we need to check to see if our patient is a high risk. I think that we can tell from the severity of the disease as well as the marked thrombocytopenia and leukopenia. And this is also something that was brought up by Dr. Sinchi. So what is important is that there are some case definitions, and I can show you an article at the end that has the case definitions for all the different South American hemorrhagic fevers. I'm using the one from Argentine hemorrhagic fever because it's the one that has the most cases. So usually we're going to have a case that is probable when there's an acute febrile illness in a patient with possible exposure to an Argentine hemorrhagic fever endemic area and to field rodents within the previous 3 weeks. And then we're going to confirm the case when we actually have laboratory confirmation of Hunin virus infection. In the areas that are endemic, the combination of thrombocytopenia less than 100K and leukopenia less than 4 has a sensitivity of 100% and specificity of 71% for Argentine hemorrhagic fever. So initially, our diagnosis has to be clinical until we get the confirmation. And the reason why I'm saying this is because in Argentina, they will be able to test for Hunin virus a lot easier than we have here. So in the US, we'll get there in one more slide, and like how we test for this. So that's why the clinical suspicion is very important, so we can start talking with people early so we can actually get the treatment that our patient needs. So in the acute phase, we're going to try to take a sample of serum, blood, and urine before we give the patient convalescent plasma so that we can do the pair sera and do the seroconversion. We can do viral detection with PCR. We can do ELISA, or we can do the plaque reduction neutralization test as well. During the convalescent period, we cannot do a PCR because we're not going to have viremia anymore. So basically, we will try to do a sample obtained 60 days after the symptom resolution and pair it with the one that we checked before we gave the convalescent plasma. In disease patients, we can check any body or fluid for PCR. We can do immunohistochemistry, or we can as well test for immune response in the patient. How do we test in the US? So I think that because you're coming to this echo session, you know about NETEC and about our respects. We actually, as regional emerging special pathogens treatment centers, we do have access to a lot of treatment. However, none of us have access to check for Hunin virus or any of the South American hemorrhagic fevers. So we do need to do the testing at the CDC in Atlanta, or US SAMRED can also do the test if you are in region 3. But that requires that we involve public health early so they can actually do a consultation with us and guide us on how to proceed with the confirmatory diagnosis. And this is a category 8 infectious substance in the US, so it needs to be packaged by those people who are trained to dealing with category 8 substances. How are we going to treat this patient? So the main treatment for these patients is supportive therapy. The only one that has a recommended treatment is Hunin virus, that we can do convalescent plasma. So there's use, or there is off-label use of antivirals such as ribavirin and favipiravir. We do not have access to favipiravir in the US, and we can only access oral ribavirin in the US. So again, for this antivirals use is off-label. They're not approved for this, but they have been used for Lassa virus and for some of the cases for South America, particularly for Machupo and Guanarito. But there's a total of 19 cases that were studied. So we don't have great data. For convalescent plasma, on the other hand, we do know that it decreases mortality from up to 30%, in this case, the overall mortality of 16.6% to less than 1%. But we do know that the late administration of convalescent plasma will increase the risk for neurologic syndrome. There's some investigational monoclonal antibodies right now that are anti-human transferrin receptor 1. They're not currently commercially available. Basically, all these arenaviruses, particularly South American, the clavy viruses, use the human transferrin receptor 1 to actually enter the cell. So what these monoclonal antibodies would do is block cell entry, hence the virus cannot replicate. But at this point, they're not commercially available. So again, the only one that has a specific treatment available is Argentine hemorrhagic fever. However, our goal is we aim to give the treatment before the first 8 days of symptoms, but because we don't have access to convalescent plasma in the US, we would have to talk to CDC, and then we'll coordinate with Argentinian government to basically ship plasma if possible. And basically, this plasma is obtained from individuals who suffer from the disease and recovered. So what do we do for pre-exposure prophylaxis? So the general measures: washing hands, wearing boots if you're going hiking or if you're going to go to an endemic area, some environmental precautions, so like rodent control. And then the specific measures, the only one of these viruses that has a vaccine is Argentine hemorrhagic fever, and we have the Candid 1 vaccine. So basically, this vaccine is recommended from the age of 15 for individuals residing or traveling to the endemic areas of the disease in the provinces of Santa Fe. So the patient that was described by Dr. Sinchi was from Rosario, that is in the province of Santa Fe, Cordoba, Buenos Aires, and La Pampa. And the vaccination should be carried out at least 1 month before engaging in any risky activities to ensure protection. Candid 1 vaccine is a single dose of a live attenuated virus. And as Dr. Sinchi said, it's effective in like 95% of the cases, or to prevent 95% of the infections. And this was developed in the 1990s as a coordination or collaboration between the Argentine Ministry of Health and the Social Action and the U.S. Army Medical Research Institute of Infectious Diseases, or US SAMRED. So for post-exposure prophylaxis, there is no data. So as we said before, the country that has the highest numbers of cases has been Argentina, but because they have access to the vaccine and they do have convalescent plasma, the need for post-exposure prophylaxis is different as if we were, let's say, in the US. However, both ribavirin and favipiravir have been used for mochipovirus and guanarito. We don't have any good data to suggest that, but it has been used. Passive immunization and immunomodulatory agents are under investigation right now. So for infection prevention, this is for the US is a category A PPE. We're going to use a PAPR with double shroud, 3 layers of gloves, impermeable suits, booties, category A waist, and negative pressure room. This doesn't mean that this is exactly what they're doing in all the other countries where these diseases are endemics, but this is the recommendations for the US. And the other important thing is like the only way to diagnose this is to get a good history, right? So when we talk to patients and we detect, particularly now that we're talking about the workup, if we have patients presenting to either our urgent cares or ERs or clinics or standalone clinics, we need to take a good time to ask about like the right questions. The place of residence, the occupation, travel, food storage, animal exposure, sick contacts, and all within the last 3 weeks. When we're thinking about these pathogens, if we're thinking about something else, we can go a little further out. But when we're thinking about patients with viral hemorrhagic fevers, we usually go up to 3 weeks before the presentation of the patient. And we can tell how the differential diagnosis will differ based on where the patient is coming from. But the history is actually key. And thank you very much. I know we are kind of in a crunch, but this is the article that actually has some more resources and specific about each of the viruses.
Thank you so much, Dr. Frank. And while we're moving to our final presentation by Dr. Pavlik, I will remind the audience that we will be providing resources next week to everyone in attendance, and they will include slides as well as references that are made note of here. Thank you, Dr. Frank. And so with that, Dr. Pavlik, the floor is yours.
Great. Thank you so much. Good morning. Those were great presentations. So I won't spend a lot of time doing information on the epidemiology of these diseases, but focus on some public health action. Let's see that move. There we go. So really, as we prepare for high consequence infectious diseases, such as these viral hemorrhagic fevers, it really requires our healthcare providers to plan for these rare but high impact events, It's really about the systems, the people, and the practice, ensuring that facilities have team designations, have recognition of these high consequence pathogens, policies and plans in place, and really that standardized questions that are being asked to gather that information that really flags that identification of a high consequence pathogen. And really important to have that consistent training that's ongoing among the facilities. So as mentioned, we're focusing on these South American hemorrhagic fevers, endemic in South America, transmitted primarily through rodent exposures and can cause severe illness and death. So I really want to focus on that identify, isolate, and inform. And this is just a snapshot of one of our flow charts for this. And I'll focus on each of the areas shortly and try to move through these quickly. So the first piece is that recognition. Early recognition is critical. So thinking about those key elements to identify. So did a patient travel to an endemic area? Have they had those exposures to rodents and their environment? And did they present with compatible symptoms? So presenting with those prodromal symptoms, it's really critical to track that information on all of their clinical picture. When did these things start? Their flu-like symptoms, their high fever, headache, malaise, muscle pain, potential vomiting, and then, the timeline when presentation of severe symptoms. So next, looking at isolation. So while many of these South American viral hemorrhagic fevers are rodent-borne, person-to-person transmission can occur, as you've heard in our previous presenters, through exposure to blood and body fluids and potential healthcare procedures. So really that isolation measure should include placing in a single room and appropriate precautions and proper PPE usage for those patients. That quick notification. So Informing refers to that timely notification to our appropriate internal and external partners once you've identified a patient to have suspected or confirmed high consequence infectious disease. So it's essential to protect our healthcare workers and the public, activate our public health response and potential contact tracing, and ensure appropriate testing, transport, and treatment. And then, of course, to prevent any potential secondary transmission. So who to inform? So usually much of these occur first and simultaneously are internal notifications in your facilities to infection prevention, hospital administration, or incident command, and then to public health, of course. For Georgia, we have our 24/7 public health hotline, 1-866 Pub Health, that you can get a medical epidemiologist at any hour. And I'll talk a little bit about that. So Dr. Frank really mentioned collection of that really good history, and this information is critical to help public health with our next steps and risk assessment. So of course, the basic patient demographics, but that travel history, including specific dates and travel locations. Those exposures, so any sick contacts, funerals, animals in this circumstance, and any other healthcare facility visits that they've had prior to the one that we're discussing. Current symptoms and progression of illness, any tests that have already been conducted, underlying health conditions, current medications that they're on, as well as vaccine history and any potential prophylaxis taken. We often ask about malaria prophylaxis when persons have traveled to a variety of areas, and then the current hospitalization plan. And then some additional information that can be helpful to public health may include if they speak another language, as well as if they have any co-travelers. So if they've traveled with someone to that particular country, if they have family members at home that are waiting, so that we can help with that additional follow-up. So a medical epidemiologist will conduct a risk assessment by using all of that information provided to determine if there's a risk of a high consequence infectious disease. So of course, if a risk is of the high consequence infectious disease is identified, public health will identify and coordinate transportation, if necessary, to a higher level facility, if that is an assessment or treatment facility, and then also assist with guidance on specimen collection, as well as transportation to our public health laboratory, and then on to CDC if that's where testing will end up. So the investigation that would then ensue could potentially include contact tracing to identify any exposed individuals. And those exposed contacts would potentially be enrolled into active monitoring, potentially placed in quarantine, as well as would have any additional testing coordinated if they were to become symptomatic. So these are just some key principles to identify, isolate, and inform. Of course, early identification really does enable us to prevent a high consequence pathogen and prevent healthcare exposures, informing our multiple stakeholders so that everyone can gain action at a similar time and trigger rapid public health intervention and response. So I just wanted to share some tools that we have here in Georgia. We have a high consequence infectious disease screening tool shown on the screen, and I'll ensure those links are provided, as well as we have a magnet that is going to be going out to our healthcare providers in these next couple of weeks that give them the ability to quickly scan for our travel clinical assistance that identifies endemic diseases in particular countries of travel. So I know I went through that quick, but I know we're a little bit on a time crunch, so I'll stop there. And thank you so much for the time today.
Thank you so much, Dr. Pavlik, and thank you to all of our presenters. These were quite informative presentations, and especially in the setting of an illness that we don't often see here in the United States. There are a couple of questions that, of course, have come through we're going to try to get to very quickly. Dr. Sinchi, I'm going to start with you, if that's okay. And one of the questions has been, Dr. Frank mentioned that sometimes the infection prevention and control practices that we may utilize here for a South American hemorrhagic fever may be different than what is done, say, for Junin virus in Argentina. Could you describe the management setting in which you provide care for these patients? Is it a high-level isolation unit? Is it a negative pressure room with personal protective equipment?
No, no. For suspected Argentina hemorrhagic fever, we use standard precaution and droplet precaution. And also, if we have the opportunity, we isolate the patient in a private room, but we don't use other specific isolation measures because they're not airborne transmission data about this disease. This is different if you are suspecting, for example, hantavirus. That is a differential diagnosis because also we have here this disease in Argentina. If you remember, this patient traveled to San Carlos de Bariloche, which is an endemic area for Andes hantavirus. So in this case, it would be appropriate to use more appropriate isolation measures, but this is a tricky thing that I add, especially for this case, in order to think about it. But if we suspected the other disease, not, we don't have that kind of measure.
Fascinating. Thank you so much. And I just want to remind the audience here too, as a comparison, in this country, the current plan would be if we did have a highly suspected or confirmed case of a patient who is symptomatic, they would likely be treated in a biocontainment or high-level isolation unit at this time. Thank you, Dr. Sinchi. Then Dr. Pavlik, I just wanted to move to you quickly. There's been a lot of questions about the pre-positioning or potential pre-positioning of medical countermeasures for this. And I'm just curious for one perspective on, to your knowledge, has the United States thought about this from a public health perspective for convalescent plasma? As Dr. Frank mentioned, we would have to import it from Argentina. And then just quickly, from a quarantine and isolation perspective in Region 4, what are our plans in that situation from a public health standpoint?
So in respect to your question about the convalescent plasma treatment, I think I would need to reach out to our Director of Public Health Preparedness to identify, what the current status is of that in respect of our medical countermeasure program. So I'd be happy to come back to that with that information, but I have not heard anything specific. Related to your question about quarantine within the United States, specifically in Georgia, it is something that we are always thinking about with high consequence pathogens and the locations as to which we could quarantine a close contact if, in fact, we did have a confirmed high consequence infectious disease. And, we have isolation and quarantine plans across the state and would be working with our local jurisdictions to identify the best possible location that person could be. Of course, if they were a resident, their home location may be the best option. But, as we are talking about World Cup and planning for a large number of, international and national resident or travelers coming to Georgia, we would be looking at other locations to place them at. And we would work with that local jurisdiction to identify that and as well as do that daily communication for active monitoring of those persons.
Fantastic. Thank you. Dr. Sinchi, I see your hand up.
Yeah, in order to respond, recently we have a recent experience to sending immune plasma to the US. We coordinate together with the special pathogen branch for CDC there in Atlanta. So if you have suspected cases, we are develop a protocol to do this on time to treat the patient. So I suggest that you maybe contact them and in order to they contact us and we are working specific at this time in that protocol.
Thank you so much, Dr. Sinchi. And for the audience, yes, we will be providing these resources afterwards to help you all with your preparations. Yes, Dr. Frank, I think you may have the last words here in the interest of time.
Well, I was typing an answer, but I think I'm going to just say it out loud. So someone asked, why don't we have availability of convalescent plasma for either LASA or like you need in the US? And the reason is we need recovered patients to actually have convalescent plasma. Neither LASA nor any of the South American hemorrhagic fevers are endemic in the US, so our access to recover patients is pretty low. And in order to import convalescent plasma when we have a patient, convalescent plasma is considered a human organ. So basically, it's hard to import organs from other countries, and that's what requires government agencies' involvement at both countries, the receiving and the one that is going to be sending the convalescent plasma. So it's not something that we can hold here. Regarding the medical countermeasures availability for all arenaviruses, let's say Lassa and all the South American hemorrhagic fevers, what are the limitations? There's a lot of studies going on medical countermeasures. To be honest, there's a lot of like monoclonal antibodies that are being developed. Usually, money is one of the bigger limiting factors for the development of these places, but also at this point, because ribavirin has been used for many years for treatment of Lassa, it's hard to do a double-blind placebo control when we choose not to give ribavirin to a patient. So there's like new medical countermeasures being studied, and as soon as we know more, we'll let you know, but this is what we have right now. And
thank you so much. In the interest of time, we will have to stop there. That will end our discussion. Thank you so much to our panelists, to our audience. Before we close, we do have one more poll question that I would like to present. To our audience now, having gone through the session, how knowledgeable do you feel about the current state of South American viral hemorrhagic fevers and the potential management of a case at this time? Again, on a scale of not at all knowledgeable to extremely knowledgeable. If the audience could please vote now. And while we are doing that, I just want to again say thank you to everyone. Thank you to our technical team here at SCDP ECHO, Yasmin Thornton, our outreach coordinator and leader extraordinaire, our planning committee with Sharon Venersdale and Ish Mehta. Thank you so much. For feedback and further information, please check the links here and on our website. If we could please get the result of that poll up on the screen. And it looks like our panelists have made some significant progress with our audience, so that is absolutely fantastic. I know I learned a tremendous amount today, so thank you all so very much. Stay safe, and we look forward to seeing you again soon.